This is like the #1 treatment that I do when somebody's coming in for general healing. What we did this morning is pelvis, that's the soup bowl. Then you can do abdomen. If somebody's driving through your area, like I said, you can combine it, but they are two very intense treatments, so I normally don't combine it. It's just for you guys here. So, when I go to do it, everything we read through first, it's all elbow work, complete elbow work first before we ever go for a lift. If I see somebody is over, I would say 60 pounds overweight. So it's not just distension of the abdomen, I can see it falling down and out. We want to do abdominal restoration by going in with our elbow and pulling those adhesions apart, but you are not going to really try to lift. What are we trying to lift? There's 30, 40 pounds here. You're going to get this up on their chest. It's not going to be possible. So we want to teach them all these things, how to detox, and I'll just focus on my elbow work because that's what's going to pull those adhesions apart to create more flow in there anyways. So if they are morbidly obese, you're not doing the lift. We'll just do some elbow work to get stuff moving. The lift is pointless. If I'm working on a man and I can see his abdomen's out to here and it's not all fat, but I can tell it's all gas and inflamed organ tissue, what am I lifting? I'm not lifting anything. I can go in there and I can open up the adhesions to create way better flow, to get some of that plaque off the inlining of the intestinal wall. But I'm not going to be like, oh, by the end of this, your stomach's going to be flat. That's not a thing. So they got to do a lot of the work themselves, and we work in tandem.
The hiatal hernia, I have a guy that has that.
Mm-hmm.
He's really old though, and stiff, and
Then it'll take you multiple. Well, if he's not going to change, then you're not going to do anything. But the thing is, you're going to relieve some tension in here because the stomach is now popping through the stomach sphincter by the diaphragmatic hole. And that's what's getting stuck up there because they burnt out along that hole so much that they created like all that crystallization buildup. So when the stomach popped through, it actually just can't get back down through that hole. So you can relieve some of the tension in there, but if they're not going to change anything...
I've never seen anybody do it either.
Because it's rare. People think they have a hiatal hernia, but generally they have hiatal hernia symptoms. It's like major heartburn. It feels like my stomach's in my chest. A hiatal hernia is when the tissue actually pops up through the diaphragmatic hole and you're going to see tissue.
It's like an alien.
Yeah, it's like a little sac right here. People know when they have a hiatal hernia. You can't be like, I think I have one. No, we don't think. And so what we're doing at the very beginning is pretty straightforward because it's what we just did for the pelvis too. We're always going to start with the lower abdominal triangle because that's going to hit these lower abdominal organs, getting it in preparation for us to lift it. Because we have that large pubic bone here in our hip bones, and so as this waste putrefies our gut, things start to get really icky, sticky. We call them adhesions here. I would call it scar tissue in the knee. It is still just scar tissue, but picture adhesions like if I just put glue in between your intestinal organs and stuff is sticking together, because generally it should be slimy. They should slip past each other. If somebody has a really open intestinal tract, I can play around in different areas and I'll hit their spine in multiple areas because their organ tissue will separate very easily. And so that might happen for somebody who's super toxic too, but they have a couple areas where it's not that bad. But a couple areas are super sensitive, really inflamed, really backed up and tight. So you got to kind of monitor that as well. Generally, when we go to do the lift, people always ask while I'm doing the non-surgical if I can feel the transverse colon immediately. Sometimes I can feel waste, like actual poop, within the transverse colon as I'm working it because it'll feel like it's full. And like it'll make them want to go to the washroom. Sometimes I'll normally figure out where the transverse colon is sitting when I go for the lift. And I'm doing all these hand techniques to actually lift the tissue back up. But as the integrity here gets so toxic, it's not about you having abs. It's about the integrity has gotten so toxic that the muscle tissue inside of that is weakening. And this starts to fall down. Gravity pulls everything down. And as it falls down, we get these like adhesions and roots starting to latch in because it wants to head to bones because that's where most scar tissue builds up. It hangs out around bone ledges. This pubic ledge is a very prominent ledge for the scar tissue to leach onto and hold. So you'll get tons of bands and strands built up along here. So I really want you plowing out and cleaning this area out today. But if you're pretty tender from when we just did the pelvis, be mindful of that. So first off, I'll go through the organs and kind of everything going on here. So we have beginning of the large intestine. So stomach is up in here. We all know that. And then stuff comes down into our small intestine first. Small intestine is all within here, but I touch that afterwards. I actually go for the large intestine first. But we're going to begin with the abdominal triangle. So that's starting in the umbilicus and working all around the small intestine. Then I want to shoot down, come through here, about 1 inch down and 1 inch to the right is going to be that ileocecal valve. So that ileocecal valve is that port that should be allowing starting to become digested food to head to the large intestine to become more waste so then we can pass that bowel movement. We have the cecum pocket right here on the right hip. Then we got the ascending colon. We call it flexures because it's just a turn. So the hepatic flexure right here is going to be the liver is huge, and then the gallbladder, we're stimulating the gallbladder, you're never going to be working directly on it. The gallbladder's tucked in behind it. Then we got our xiphoid process right here. That's going to be that stomach trigger where that stomach sphincter is, because that stomach can get inflamed and start pushing up on this area. So just off the diaphragm, we got our xiphoid process. We got our splenic flexure right here, and that stands just for spleen and stomach. Then this area is going to be right across here, just above the belly button, is that transverse colon, where most people should be. Majority is not. Over time, it starts to fall down. It's going to get up to the belly button. Then it's going to fall down lower. Then it's going to put more pressure down here. And then I have some women come in, some men come in. They'll go to the washroom. They'll go number 2. Some of the rectum will actually come out from itself, and they'll have prolapses. I'll have women who have had vaginal cuff surgery from the Da Vinci we were talking about. As they go to go pee, half of their uterus will pop out a little bit, and actually they'll have 2 to 3 inches of their uterus pop out of their vagina. And so doing this work, getting them to do cleaning out and refurbishing this by having a perfect day diet, doing nice abdominal exercises, doing the padding and the clapping, the belly button therapy, doing the abdominal lift techniques, that does not need to happen. So we got that transverse colon here, right above the belly button where it should be. We got descending colon here. Last turn of the large intestine, big boy over here, that is sigmoid. So a lot of colon cancer hangs out in this area. Then we just shoot out here to come down to the rectum and anus area, which is going to be here. And then for men, of course, we got the prostate behind, women, ovaries, and uterus, if they haven't had a hysterectomy.
Prolapsus means you stick it out, coming out.
Prolapsus means it's falling down, and then so the prolapsus is mean it's actually coming out now.
Yeah, okay.
Yeah.
How about the bladder? Is that behind?
Bladder's behind. Bladder's tucked in behind. That's why as soon as I finish that sigmoid turn, once I get to here, people already start talking about And if you need to go to the washroom during this treatment, if your client needs to go, you literally need to remind them, you gotta go. You're breaking the treatment to go to the restroom, because you're gonna get that much deeper. You're removing that much more stuff. You're buffering down that much more tension that's in the area for you to pull those adhesions apart. So that is pretty much the track of what we're gonna be covering when we do this. I'm beginning with the abdominal triangle, so we're going to start in the umbilicus. And this can be a very emotional area for most people. What if they've had a miscarriage, and so they have some form of attachment to that child? What if you have a really awful relationship with your mother, and you just really haven't forgave her? This is a large emotional area for a lot of people. So we want to open up that umbilicus, small intestine area. Then I'm going to start to come down to her right hip, but my left side. So working down 1 inch down and 1 inch to the right, coming through the ileocecal valve, and then I want to work everything to the right hip in itself. So I just say focus here for a moment, and then bring everything into that right hip and focus on the cecum pocket. Then I head back up to the umbilicus, and then I'm going to head down the descending colon and work all around the sigmoid. Play that sigmoid out, and then I'm going to come across the top of the pubic ledge to where those roots are attaching at. So I'm trying to open up that area. After I've done that from face to face, I'm going to flip around, do it again from face to feet. Generally, we didn't do pelvises this morning, that's where you just stay face to feet, and you would do the hip flexors, starting on the medial, down to the insertion of the groin, back up, on top of the hip bone, sartorius and gracilis in the thigh, back up, outside, tensor fasciae latae on the outside, just to be in line with the pelvis. And you would go face to feet and face to face, doing ambidextrous with that. We're all kind of good there? Then you would flip over, do the exact same thing on the second hip flexor, and then I'm still ending up face to face for the whole abdominal structure. So I've done the abdominal triangle, I've done the hip flexors, now I'm starting. So think of it, because there was a lot of steps we just read, especially not just the elbow work. We stop at step 4 with the elbow work, but we go to step 12 with the lift, because there's so many different types of lifts. So it's just practice, practice, practice. But with the elbow work, it's not that difficult. We want to think of large intestine first, small intestine directly in. So large circle, small circle in the middle. Pretty easy? Okay, so starting at the cecum, and I give you guys an allotted time. That allotted time means either you're really slow with it, and this week, I can just even say, because I do 1 treatment roughly every night after class, 1 to 2. This week I've done 3 abdominal restorations. One person I did, I only made it around their whole large intestine once. Another person, it was like 11 times, because they were so hypersensitive, I had to continuously move. The other person who I made it around once, I slowly took my time opening up each individual area before I moved along. So there is no set treatment for one person. It has to be adjusted all the time. But you guys have a set amount of time, and we are going to focus on the large intestine. I normally want you to try to get 1 to 2 laps minimum. Easy all around it, especially while we're learning. So I'm going to start at that cecum, and it's just me being mindful. I'm like, okay, up the ascending colon, I know it would go vertical. So I don't want too much face to side on that. I just want 45-degree angles, pulling those fibrous tissues apart more so. But when I'm trying to hit that liver and gallbladder, you're going to see me get on like a weird little angle. So I start at the cecum, open up that pouch. Since it's the beginning of the large, it's where the small and large intestine connect, and it's the beginning of the large intestine, that's where that valve can stay open, and you're flushing back undigested food and digested food, and it can get stuck in the pockets here, and that's why we say we create, it's an area for worms more so. So I'm going to hang out in that cecum. I'm going to work my way up the ascending colon. Once I get to the liver, I'm tucking myself on an angle, and I'm really going to try to get under those ribs and loosen off that hepatic flexure, the liver and gallbladder area. Once I've done that, I'm going to work my way. I just want us lightly touching on the xiphoid process. Try to leave it alone right now, though, because we're doing the breast restoration tomorrow morning. So I want you just off the diaphragm, around that stomach sphincter, diaphragmatic hole. And then I'm going to come off to the splenic flexure and really work the spleen and the stomach all the way to the base of the ribs. Once I get to the base of the ribs on the left side, that's a guide to stop. I'm going to stop there, and I lift my elbow up, and I place it back at the hepatic flexure area, and I want a complete face to side for this one, because then I plow right across where the transverse colon should lay. I don't care if it's dropped either, though, because then I know that these organs here have been inflamed and they're starting to fill that tissue gap in a little bit. So it's like I want to clean out to where I'm pushing it back up into.
Making room.
Exactly.
Got it.
Make sense though?
Yeah.
Okay. So once I stop at that splenic flexure, base of the ribs, lift up, place the elbow, and then I'm going to work across the transverse colon, playing my windshield wiper as thorough as possible. Once I get back to that splenic flexure, I will go back face to face, because I know that now I'm going to be heading down the descending colon. It goes vertical again. So then I'm going to pull down the descending colon with my windshield wiper technique all the way to the sigmoid. I want you hanging out in the pockets. We have 6 main pockets. We got xiphoid process, we got hepatic flexure, splenic flexure, cecum, pelvis, and sigmoid. Those pockets need a little bit more time. You're going to have more stagnation there. So come down that descending colon, really hit that sigmoid, pivot once again, face to side, because I'm constantly doing these 2 angles. Then I'm going to plow across. I don't want you on top of the pubic bone. We just did it. But in the book it says come underneath it, on the ledge of it, and on top of it, because that's where the anchor and down is happening. We just did the pelvis. So I just want you off the ledge, trying to carve out underneath it. Carve all the way over, back to the cecum, and depending on how much time you have, you can do multiple laps of that. Every time I do a lap, though, I stop at that splenic flexure, lift up, place, come across the transverse colon. That's the only hard thing to really remember when you're doing the large circle is stop, lift, place, work across.
So what if it's a larger person and it might not actually be there?
That's what I just said. We're cleaning out the area that it's in, because when we go for the lift eventually, we want to clean out where those other organs have started to fill the gap in.
Okay.
Yeah, so it's just making room. So after I've done that large circle though, and I've done it a couple times, that should take me about 10 minutes, I'm going to head to the small intestine. So I don't care where you place your elbow because the small intestine is such a small area, you're going to do multiple laps. There's no way you're not going to. So I can place my elbow here, above, to the side, other side, doesn't matter. And I'm just going to work all around the belly button, playing my windshield wiper from face to face and face to side. And when we're working that abdomen, remember, you can't go in and out within the depth constantly because it's going to be a washboard sensation, like wishy-washy, kind of like that motion. And I don't want that, so I'm always going to be going to the depth where I feel the pushback, and that's when I start my movements. So I place my elbow, and I'm going to work all around that small intestine, playing my angles. Should take me about 5-7 minutes. Then I come directly into the umbilicus, and I'm hanging out in that belly button where she doesn't like already. So some form of an attachment, and I can feel something's attached even just on my finger right there. And so I'm going to go in, play my angles, opening that up. Flip myself around. People can feel really nauseous during this treatment. In all honesty, I've probably done over 2,000 abdomens. I've only ever had 2 people puke during the session, and when they puke, it's like acid. It's more of like an emotional thing. It's like, ugh, like just let it out.
So it's good.
Yeah, so it's a good thing.
That.
Yeah, and so just always have like a little trash can in the room, but they're gonna tell you. It's not like they instantly sit up and vomit. It's like, oh, I'm feeling really nauseous, like I don't feel good right now. So you say, I'm gonna take a little break, alcohol massage, be like, if you need, sit up, grab some water, they still feel nauseous, bring a trash can, and it's usually just like a little bit of spit up.
And would you keep going?
After they finish their thing, oh yeah, I'm gonna go back in, we just continue along, play with it. So after I've done the small intestine, and I've come directly in the middle, my elbow work is done from face to face and face to side. So then I would just flip myself around, and I'm going to do everything the exact same from face to feet and face to side. So we go large circle first, up, through, across, stop, lift, place, then through the transverse, then down the descending, then back to the cecum. I'm going to do that a couple times. This is face to feet. Then I'm going to go for the small intestine, face to feet. Then I go for the umbilicus, face to feet. After I feel like I was thorough with everything there, then we can head into the lift techniques, which there is 7 different lift techniques. We're going to go from fist rotation to thumb square to inchworm to midline to colon ringing. There's a lot. So when you're doing it, this is a treatment that you should be practicing a lot on your family. And you're like, just get your hands in there and move stuff around. You're going to watch their body. You're going to see where their uncomfortability lies, and you're just going to monitor that, and you're going to play with it, and you're going to feel different things. So this is one to practice a lot. Are we all okay with the elbow work part?
Are you going to actually feel
Yes.
like different organs in your elbow, or will it?
You're going to feel different like adhesions. You're not going to be like, that's the shape of the liver. You're not going to be like, that's the shape. Sometimes, once you've gotten in tune with it, though, like right today, you're going to be like, I don't really know what I'm feeling too much other than tougher areas that are compacted. Once you've done it 30, 50 times on different people, you're going to be like, I know exactly what that is. And when you go in, I'm going to be working around, I'll find little fibroids on people, and I'll be like, oh, that's like a little fibroid. And I'm going to be like, you want to go in, loosen it off. But if I'm hanging out anywhere by the descending section, by the sigmoid, and I feel like it's changing really quick, but it's a very compacted area, most of the time it's actually poop. And so you're just going to be kind of moving along. At the end of the treatment, I always tell clients to monitor how they're feeling, hydrate really well, take some stuff, but if their bowels move, they might move fantastic. I've had so many people just be like, oh, I've never had a bowel movement like that, like I did after the treatment. Then the next day I'll have somebody call me and they'll be like, I still haven't had a bowel movement. That means we're getting plaque off the inlining of that peritoneal, that intestinal lining, and that plaque is actually getting jammed up here because they're still a little too dehydrated. So I'll say, take extra daily cleansing tea, maybe do a coffee enema to flush a lot of that toxicity out that we just removed off the walls.
More hot water. More hot water.
More hot water, exactly. And like hot water is the number one. People don't realize it, and they're like, I just don't like it. It makes me feel nauseous. Well, it makes you feel nauseous because it's removing the plaque. You think about it, you have dried ketchup or egg yolk on a plate. Wash it off with cold water. How long is that going to take? That's some elbow grease to get in there. But if you're really putting that hot water on there, eventually it's just going to be a clean plate. So I'm going to begin with